Yeah, Fabian?
Yeah, I'm here.
Yes. Fabian, please open your WhatsApp and have a look at the photograph I sent you. Would you please care to comment on this photograph and then give your diagnosis?
It's a colored artist picture of the left side.
Your voice is not clear, Fabian.
It's a colored artist photograph of the left side.
Of the left eye?
Sorry. Yeah. Yeah, it's a colored artist photo of the right side.
Okay.
Showing blackish bony spicules from the periphery.
Okay.
The disc in macula looks normal.
The disc and retina disc and macula looks normal.
There is bony spicules that is present on the periphery towards the center.
Can you be a little louder, buddy? I can't hear you.
Bony spicules are present that are towards the center from the periphery.
Bony spicules are present towards the center or the periphery. What did you say?
From the periphery approaching towards the center.
Okay.
Probably it could be retinitis pigmentosa.
Okay. What sort of symptoms and signs would you mentioned a few signs, but what symptoms and signs would you expect to have seen in this patient? So what is the most cardinal symptom that you're supposed to see in retinitis pigmentosa?
Night blindness.
Yeah. Fabian? Anything else?
Yeah, he will be having problems with the night vision.
Yes. So night blindness is the most cardinal thing, without which your answer will be incomplete. What is the second most important thing you need to think about?
Progressively his periphery will be restricted.
His peripheral vision, he'll have a peripheral vision field.
Yeah.
Okay, agree. Would you agree with me? Okay, fine. We'll stop here. Can you tell me a little bit about signs? What signs would you see? There are three important signs. Alia, would you like to answer this?
Sir, like first one will be bony spicules.
Okay, when you say bony spicule, would you like to elaborate it a little bit? So bony spicule is the
Basically,
name
it
of a
is
shape.
loss of the photoreceptor layer.
Loss of the photoreceptor layer, how would you like to... Are you defining RP or are you giving me the signs that you are able to see?
Signs in the sense, sir, like what am I saying on the fundus only,
Yes,
right?
yes. What you are able to see during a clinical examination. Because for example, if you say loss of photoreceptor layer, then I would like you to mention on OCT I would see that there is a loss of photoreceptor layer.
Yes, sir. Yes, sir.
What
Photoreceptor
I
layer.
would rather want you to do is, looking at this image, what signs are you able to decipher?
Then there, sir, I'm not sure, but I feel that there is certain kind of macular edema present. So there would be a loss of central field as well.
I would not start with that. I would start with the most important things, and then probably go for a CME is what you're trying to tell. Cystoid macular edema is possible. It is seen in cases of RP. But what
Then
would
color vision is affected.
uh, are you sure color vision will be affected?
Yes, sir.
Okay. Fabian, would you like to mention a few signs looking at this image? So you both had mentioned something called as bony specule. Would you elaborate on that sign a little bit? So there is hyperpigmentation in a bony specule configuration in a perivascular pattern in the paracentral and peripheral retina. Okay, that would be your most important sign. That is the most pathognomonic for RP, like most of you have noted. Similarly, Alia was saying something about. So Fabian mentioned that the disc in the macula was okay, and Alia mentioned that the macula seems to have edema. You both are right and you both are wrong. Actually, Fabian is wrong about the disc. Because the triad, there is a classic triad. There is a classic triad without which RP cannot be diagnosed. Okay? The classic triad is the first is the bony specule configuration of the peripheral retina, where there is hyperpigmentation in a perivascular pattern. Okay? Secondly, you have a waxy disc pallor. That is very pathognomonic. You cannot get away with not saying that. So, I mean, I agree with Fabian. It might look like this is a normal disc, and diagnosing discs solely without context is very difficult. And anything looks pale, anything looks pink sometimes. But as soon as you know that this is an RP, just go for the classical triad. You have to mention it's a waxy disc pallor. You have to mention that there is hyperpigmentation in the peripheral retina in a perivascular pattern. Having said that, what is the third classical triad? Is in a meeting now.
Arteriole.
Yeah. Yes.
Attenuation of the arteries.
Yes. Yeah, that's the third most important point. Having said these three things, you are good to go. Now, on top of that, Alia was saying something like macular edema. There is chances of macular edema happening. It's not impossible in this thing. There is also chances of. I think what you're trying to tell is that membranous type feeling that she's having over the macula. That could also be
ERM.
ERM. That could be an ERM as well. Now, why there is ERM is because the astroglial cells in the retinitis pigmentosa, because there is regeneration happening, they are trying to repair the retina, and that repairing is causing a membrane to form on top of the retina. So the ERM is there. So that could very well be an ERM. If you say ERM also, you will not be wrong. Now, having said this, so Alia mentioned color vision. Okay?
Yes, sir.
Are you guys able to hear or see me? As long as you guys are able to hear me, it's enough. So Alia mentioned color vision. Would you like to review that point, Alia, or are you okay with that point?
No, sir, I would like to go forward with that point.
Okay. Would you like to justify why there would be color vision issues in this people?
Sir, because there is a waxy disc pallor, then there is loss of photoreceptor layer, and according to the color theory, photoreceptors are there for colors.
Okay. So then I would like to ask you, how many types of photoreceptors are there?
2 rods and cones.
Rods and cones. And classically in RP, which type of photoreceptor is affected?
Rods.
Rods. And what is the main function of rods?
Photopic vision.
What did you say? Scotopic or photopic?
Scotopic.
Scotopic. So does scotopic have much to do with color?
No, not much. But there is waxy disc pallor is there.
See,
Neck.
waxy disc pallor is there. I won't disagree with that. But keeping things simple, let's talk about night blindness first. Okay? And night blindness has to do with rod, what do you call them? Rod dystrophy. On top of that, you also have a peripheral pigmentation in the area where there is a rod domination. Okay? The central part where you do have these cones, they seem to be fine. Now, if you want to push this point further, I would not disagree with you that cones do get affected in RP, but not nearly to the same degree to what happens to the rods. In fact, if you would call RP a disease where rods are getting affected, you would not be wrong. So, what would be expected out of from most probably will be the patient will have a night blindness. You said something like, did you say day blindness?
No.
You said color vision. I would rather expect you to say night vision. Night vision, or the patient will be nyctalopic. Okay?
Okay.
On top of that, if you still want to say, there have been cases where day blindness does also occur. I will say yes, you are very right. There have been cases in extreme stages of RP where there might also be central vision or cone dystrophy also. I would not disagree with you. So at this point of time, I would like to ask you, I think it's understood by everybody that there is night blindness happening. I think everybody agrees with it. I would like to ask you a controversial point. These people also complain of day blindness. Why is the day blindness happening? And it's not the cones. Cones are fine. So one of the favorite questions by Dr. MS Sir, when MS Sir had a RP case in FRCS Glasgow, he had asked somebody this question. The question is, maybe he might have asked you as well, I'm not sure, just to show you how FRCS works. Because he has asked me. The way he has asked me is, so Fabian, are you with me? Your video keeps going. Yeah. So I can't see you. So the way he has asked me is, there are some ocular associations of RP. So this is one way of answering, one way of asking the question. In an Indian setting, this is how it would have been asked. What are the ocular associations of RP? On the other hand, the other way of asking this is, will you send a patient of retinitis pigmentosa home and not worry too much about it? So Alia is shaking her head no. I'll wait with Alia. I'd like to ask Febin this question. So Febin, buddy.
Yeah.
Did you get the question?
Ocular associations of RP.
Yeah. My question was, would you send this patient away to his home and not follow up with him, or what? Okay, so you've diagnosed RP. Will you send this patient, or what will you do with this guy?
If it's a late stage, then there is nothing that can be done. But if it's an early stage, we can do a close follow-up.
Okay, why will you call him back? What are you trying to look for?
We can do a visual field testing or a ERG in the later stages.
Okay, visual field is gone, and ERG is showing dark adaptation is not good. You have done it in these are testings that you're supposed to do in the first meeting itself. You don't send the guy and call him back. You do it as an investigation. Now you've done all that, you've diagnosed as an RP. You send the patient. Would you ever call him back? Because you yourself said that there is no treatment to be done. So why are you calling him back? Why are you troubling him? Or would you trouble him, or would you not call him back? Retinitis pigmentosa. If I would have asked you this question, maybe you can give me 3 diseases. Can you give me the ocular associations of retinitis pigmentosa? Does anything happen in the lens? Does anything happen in the angle? Does anything happen anywhere else?
Like
Yes, Alia, what did you say?
cataract, no. Like lens cataract will be there, sir.
Yeah, which type of cataract will be there?
Like zonular.
No, posterior subcapsular cataract.
Yes,
Okay?
yes, sir.
You will call the patient back to look for the development of a posterior subcapsular cataract. In fact, in ulceroma, whenever we have an RP case, we are least bothered with what to do about this guy for the retina. Because his peripheral field is gone. They are very comfortable with their life. They are very happy with their life. They just are okay because their central vision seems to be doing pretty well. That is why I was trying to disagree with your point about cone dystrophies and color vision. Because when you talk about a homarlopia, you have this issue. But here I am contending a point where I am telling that in some cases there will be day blindness as well. So that day blindness is actually due to the posterior subcapsular cataract that is there. There is glare and there is day blindness as well. So night blindness is happening due to the bony spicule thing that is due to RP, classic RP. But there are certain conditions where there is day blindness and there is decreased vision. So decreased vision, central vision can happen due to CME like Alia told or due to PSC. This is two things you should be worried about. So you would call the patient back, Femin, to look for these two things. Okay? So what they do in FRCS is instead of asking you what are the ocular associations of RP, like you might be able to answer that pretty easily. But if they ask you, would you send this patient for a follow-up and not call him back, or what would you do with him? Then we get confused. So this is how they ask in FRCS Glasgow, it seems. Okay, so far so good. Now, should you, okay, so I had, at the starting of the class I had mentioned that this is a 25-year-old boy with RP, as you can see, and he seems to have day blindness as well, with a very bad central vision. Okay? Is there any significance for the fact that I mentioned his age?
Yes, sir.
Yeah. What significance will you place on the age?
So, like, RP is usually a congenital disease, sir. There is a genetic predisposition.
Yes.
Probably the parents might be affected too. That's why it got manifested so early.
Okay. I partly agree with you. So what you are trying to tell is the age is significant because it is genetic. Okay. It is genetic, I agree with you. But the age is significant because normally symptomatic RP, like you call it, most of the time when you get a patient with RP, you don't have a total segmental RP. You have a sectoral RP, superolateral, inferomedial. Very rarely do I have ever seen a full RP. If I have seen a full RP, he's a 55 to 60-year-old guy with a long standing RP. Most of the time, your patients will come with a sectoral RP. So, normally symptomatic RP, like you call them, only starts around 40 to 45. In the books, they tell you that it starts from 30 years old, but the time you start feeling anything like a peripheral visual field loss or night blindness, he's already 40, 45. And by 50, 55, 60, he's already like full blown RP. He's like very, very comfortable with himself. He knows what it is. This guy, but his central vision is still okay. Even that old guy's central vision is still okay. For this guy, he's 25 years old. He's having extreme late stage RP along with the PSC and along with the diminished central visual field, central vision. The reason why his age is important is because where Alia was partly right is it has genetic preponderance. So the normally I don't consider the mode of inheritance that important, but in RP it is quite important. How the person has inherited this disease is very important. So there are always there are two: autosomal dominant and recessive. And then, especially in RP, you have XLR. Okay, X-linked recessive. Are you guys okay with this mode of inheritances, and how is it weak, or you guys understand them?
Sorry, sir.
Are you guys okay with this mode of inheritance things? Like, if I ask you what is X-linked recessive, what is autosomal dominant, will you be able to tell, or do you have gaps in the understanding there?
If we have gaps, we'll tell you, sir.
Yeah. So, no, because I was about to ask you, like, what could you? Okay, fine. I'll ask you like this. There are three modes of inheritance for this thing, for RP: autosomal dominant, recessive, and XLR.
Excellent.
So, which is the most common? This is the first question.
XLR.
No.
Recessive.
Recessive is the most common. Which is the most mildest is my second question.
Mildest is XLR.
No. Autosomal dominant. Which is the most severe is my third question.
That will be XLR.
Yes, that will be XLR. So the thing is, X-linked recessive. Now here I would like to ask you that autosomal dominant and recessive. Do you know how they get inherited?
Yes, sir.
Okay. So for autosomal dominant, does the mother and father both them have to have the defective gene?
No, sir.
Okay. Only the mother or the father can pass it down. Yes? Fibin?
Yes, sir.
What about autosomal recessive? Is it okay if only the mother has it?
Both the parents are carrier.
Both the parents are carrier or not necessarily carrier. One can be expressor or both of them can be expressors. All expressors are carriers anyways. So the thing is, both of them are defective gene. So, but they have to have defective gene, both of them. Okay?
Yes, sir. Yes, sir.
Now I will have the tricky question for both of you. Let's see how your genetics is. If you don't know, you can completely tell me. We'll discuss a little bit. Because it's X-linked recessive, 3 questions will be asked. Most probably, if the examiner is that kind of a guy. Imagine if the mother is a carrier, like Alia told, and if the father is also a carrier, let's say he's a carrier or an expressor, either way. What are the chances of a girl being affected with an X-linked recessive RP or a boy being affected with an X-linked recessive RP? So,
Boy 100%.
boy 100%.
Yes.
So if you say the word 100%, I was not going to ask you percentages, but if you're going to say 100%, then I will ask you for justification. Or otherwise, you said boy has more of a chance of inheriting this thing. So either way, I would like you to explain yourself.
So, sir, basically it comes down to the crossover, like mother will have XX. So if we mark one X with the infected gene and other with X, that's normal X, okay, and then father will have XY. So obviously the male will go with XY gene and X will be inherently inherited from the mother, and that X is positive, like infected. So the boy will obviously be infected.
Yes, the boy will be infected, obviously, because there is.
Is X.
Yeah, she has. I'm getting to that. Because there is one affected gene, agreed, one good gene. The father is only having one bad gene, that is one X, and the Y will do nothing to negate it. When the Y comes in, it is not negating the bad gene that the boy is getting. So, in Alia's words, the boy will be 100% affected.
50%. 50%.
Yes.
50%.
50%. 50% because the mother is a carrier.
Yes, sir.
I don't know to what extent, Fabel, are you able to follow us?
Yeah.
Okay. So, if the mother is a carrier, the boy will have a chance of getting it for 50% because the mother is only a carrier and not affected, as she is having one good and one bad gene as well. if he gets the bad gene from the mother and the only Y gene from the father, then definitely he is affected. Whereas if he gets the good gene from the mother and the bad gene, the Y gene from the father, he's okay. On the other hand, if the mother is having an affected gene, both the X's are affected, then there is a 100% chance that he is going to be affected as a X-linked recessive retinitis pigmentosa. Now here my question would be, what if it's a girl and not a boy, and the father is having a bad gene and also the mother is carrying a bad gene? What are the chances of the child being affected or carrier or whatever it is? Are you able to figure it out?
If both are carriers, then 50% daughters will be carriers, 50% will be affected.
Can you explain your point? What this is?
So you said if the father is a carrier or father is completely affected, dominant.
Either way, doesn't matter, because father is having only one X gene. So whether he's carrier or not, he's going to be expressing it either way. Let's say he's affected. Let's say his X gene is affected. Then
Okay.
the mother is a carrier.
Mother is a carrier, then obviously 50% will be affected.
Why?
The daughters.
Why not 100%? So it won't be affecting.
If two daughters are there, one will be completely affected, one will be a carrier. I mean, that's it.
Okay, what you're trying to tell is there's a 50% chance of one daughter being a carrier or being affected. Either way, however you put it.
Yeah.
No, my question is, why can't the daughter be, why have a 100% chance of being affected? Why do you use the word 50? Why not 25? Why not 100? So is there a reasoning or? So the main thing what you need to think is, the mother is having one bad gene and one good gene. There is equal chance of this good gene coming from the mother and then negating the gene from the father. So she will only be a carrier. Whereas the bad gene that is there for the mother with the bad gene that is there for the father, if they both come together, the daughter will 100% be affected. The chances of this happening are very low. That is why X-linked recessive, we close our eyes and we tell it is a boy-related disease. Because the chances of a boy getting it are much higher than a girl getting it. Because for the girl to get it, the mother has to marry a consanguineous marriage with a father who has similar genes, with an affected gene to begin with, and then both the genes are getting together and creating a 50% chance of carrying an affected daughter. Whereas for the boy, that does not matter. Even if the mother is carrying one bad gene, that's it. There is a 50% chance of the boy getting this thing. Whereas in the girl's case, the mother and the father has to have the gene. Okay? Now, what if, Anya, this is a question for you as well. What if the mother is affected, she is having both genes affected, and the father is okay? What are the chances of the child developing an X-linked recessive RP if he is a boy?
100%.
100%. Why did you say this earlier? What is your justification?
Because if the mother is affected, she is homozygous affected, like she is having both the X infected.
Yes. Because the mother is affected, she has to be homozygous, and that expression on the child, even if one of the gene goes away, the other gene is coming Y, which is not negating the X. So definitely the child will express. Okay. Febin, what if the mother is affected with both the genes affected, and the father is also affected and gives rise to a boy, what are the chances of the boy developing the disease?
Then also it's 100%.
100%, because there is no way he can get saved. He is not getting respite from anywhere. Both of his mother genes are affected. The one gene that his father could have saved is also affected. Okay, so he is 100% going to get it. Third vignette. Imagine the boy, the father is a carrier and the mother is a carrier. What are the chances of the daughter either getting affected or diseased? A carrier. Alia?
Affected will be 25%, sir.
1 second. Why did you say this?
So, one X from mother.
Okay, you give your answer first, then explain it. So you said affected will be 25%.
25% infected and 50% carrier. No, 100% carrier. Sorry, I will write down and check. I am not writing this down.
Yeah. I think I will disagree with your 25% point. It will be, no matter what happens to this girl, she is a carrier. There is 50% chance that she can also be affected. That is the right answer. I don't think 25% will be enough.
Okay, sir.
Because here you are talking about sex-linked. In sex-linked chromosomes, hardly the 25% thing hardly comes. Okay. Last vignette, then we'll move on. The mother is a carrier and the father is okay. What would be the girl child like? Febby? Sorry?
Father is normal and mother is a carrier, right?
Yes. Because makes sense that she can be a career.
50% chance.
For what? Of winning the lottery.
For child being a carrier.
What child is this? What is the child sex?
For child being a carrier.
No, what child is this? Is this a girl or is it a boy?
For a girl.
Yes. So 50% chance for the child, for the girl being a, what did you say?
Carrier.
And what is the other 50%
Carrier.
chance? Or?
Carrier or affected?
No.
Yeah.
There is no way she's getting affected.
Carrier or unaffected?
Yes. Carrier or no carrier. That's it. There is no affected in this because the mother is having only one bad gene. The other gene is already there that is good. If this good gene mixes with the other good gene in the father, definitely she is not affected. The one chance that she has, the bad gene from the mother with the good gene still from the father, she is still a carrier only. She is never affected. So this is either way it's 50% or 100%. There is no 25% sex linked. Okay. So now having gone through an exhaustive approach with this mode of inheritance, I would have to repeat once again. There are three modes of inheritance that you should know. Okay. One is autosomal recessive is the most common. Autosomal dominant is the most mild. X-linked recessive is the most severe. Now, having said this, given the scenario that I gave you initially, so I gave you guys a scenario stating that it's a a 25-year-old guy with bad central vision, with extreme RP, with PSC, what mode of inheritance would you put this under famine? "25-year-old boy, extreme RP, PSC, and central vision also down."
Yeah, it's a severe form.
Yeah, severe form. That means he's a which mode of inheritance? Extinct recessive, XLR.
It's the same.
Now, can you tell me what status of what genetic status of expression or effectivity might his mother or father have? Can you try to guess from this guy's condition? So he has to have a mother who is
Mother who is affected
or
and carried.
or a
Or
carrier.
carried.
Is he okay if the father is okay, or does he have to have a father who is also affected?
Father also must be affected.
No, no. Father can be completely okay. See, I tell you like this.
Oh, because it's a boy, yeah.
Yeah, okay. It's a boy, because boy you only need one X to get bad. So there is a high chance that his mother is at least a carrier. So that one bad gene is coming here. If his mother is affected, 100% this guy is getting affected, no doubt about it. It is irrelevant whether his father is affected or not. Okay? That is why this is extreme recessive. Okay, buddy. So, moving on from there. What, if any, investigations would you like to do in this guy?
OCT.
Sorry?
OCT.
Okay, agreed. OCT. OCT for? CME.
In the affected layers.
Yeah, CME is more pertinent of an answer.
CMI.
Okay, if you feel that the central vision is involved, the central field is involved, if you see that there is a swelling on 90D, then you can go for an OCT. Also, you can have an additional factor of looking at the photoreceptor layer. Not that anything you can do about it, but CME definitely you can help that guy. Okay. What else? Any other investigations you would like to do? Yeah, so you would like to perform a field evaluation to confirm your visual field loss, or you would just generally like to look at the staging of the RP. How bad is this guy's RP? What else? So you would also like to perform a dark adaptation. A dark adaptation with the help of an ERG. You have to tell these three things. Okay. OCT you can a little bit down the line, but you have to tell about a field loss, perimeter, automated perimeter. यहाँ पे क्या बोलते हैं उसको? ERG. Okay. When do you do an EOG? Okay, it doesn't matter. Anyways, so let's go to management. So, can you treat this guy?
Yeah, treat this symptoms like if there is any CMD or cystoid macular edema, if there is.
You can also treat the day blindness by trying to treat if there is any PSC. You can perform a cataract. And what else? Apart from that, the RP itself, there is not much success in traditional therapies, whereas gene therapy is being discussed in Switzerland. I have a friend who is in Switzerland who is actually researching this topic. So he keeps telling me there are big strides being made in gene therapy. That too is it's in Switzerland. So coming for it to come to India is a long shot. I highly doubt it. Apart from that, you can always have electrode. You can always have an electric implant as this thing. So I don't know to what extent whether they will ask you about this, but actually the gene therapy is quite exciting in RP. So it would behoove you to actually read upon it. Maybe they might ask you, or maybe if he is a no-nonsense guy, he might not ask you anything. Because definitely in the practical viva he might not waste your time in that, but in the case of a theory viva he might. He might ask you a few questions here and there. So this is regarding your RP. So some questions I would like to ask you a little bit more than that. What scotoma will you see in an HFA? What type of scotoma will you see in an HFA in this guy? Yeah, I can't see your video. Switch off your video and switch it on. Okay? Switch off your video and switch it on. I can your video stuff. Yeah, what scotoma will you see? You will see a ring scotoma. You will see a ring scotoma. You can mute yourself. You can see a ring scotoma, right? Ring scotoma. Yes? Yeah, tunnel.
Sir, which scotoma?
Ring.
Ring. Oh, ring.
You're not married yet. That is why.
Sir? Oh.
Okay. The thing is, where else would you see pigmentation in the RP? In the retina. DD. So one is old age. Pathological myopia. What are some important signs you see in pathological myopia? Cardinal signs. High myopia. Tell me three. Have you ever heard of fuse spots?
Spots, yes.
Fuse spots are very important. Okay, there are totally 6 to 7 cardinal signs you see in myopia. Okay? You can say chloroquine toxicity. You can say senile degeneration of pigmentation. These all look like RP. But the thing is, senile pigmentation is diffuse. RP has a typical peripheral pattern. You can say chloroquine, but chloroquine has a bullseye maculopathy to support it. And the patient will be a person who's taking chloroquine. It's not that everybody will have chloroquine toxicity. Some things they might ask you like that. They might ask you a few things. Where else would you see a picture like this? CMV retinitis also has some pigmentation. This thing. They are advised and they are instructed not to, for example, just like how I asked you, tell me something about myopia. They will never do that. They have to stick to RP, no matter how much they like to talk about CMV retinitis. So don't worry, you can say CMV retinitis or whatever. They won't ask you more questions regarding that. Now, does anybody know what is the reason for waxy disc pallor? Nobody will ask you this. Only Indian doctors will ask. What is the reason? Is because the whole retina is degenerated. So the astroglial cells are trying to repair the retina, and they are forming a membrane themselves. So this membrane, which eventually forms the epiretinal membrane, which is why you were able to see the shine near the macula, is the reason that is also on the disc as well. So that is why waxy discolor. I have never been able to see waxy discolor. Let me be very, very frank with you. Never have I been able to find out this is waxy discolor and this is not waxy discolor. Whereas I have been able to very clearly see boggy edema in CRAO. That is very clear. But this thing is something just, it's part of the triad, so never fail to mention it, but I don't know how easy it is to see. What else? Oh yeah. So yes, the most important question without which we cannot finish the class. What are the ocular associations of RP? Let's go from the front to the back. Does anything happen to the lids? No. Then next, what else? Yeah, anything happens? If it doesn't happen, don't mention it. Then what else? Clara, anything happens? No. Cornea, anything happens? Come on. Cornea, keratoconus. Okay? Then you have lens. Anything happens in the lens? Sorry, before getting into the lens, I would like to talk about the angle. Anything happens in angle?
In the
Angle. So open angle glaucoma.
hyperpigmentation.
No.
Hypo.
No. Open angle glaucoma. Okay? Angle is open, pigments are not there. The pigments are not dispersing in RP. They are just there in the perivascular pattern, but they are not dispersing normally. Not like tobacco dusting. This is just like it's there. Open angle glaucoma is there. Keratoconus is there. Then what is myopia. Index myopia. Also, index myopia is happening due to PSC. So both of them are there. Okay. Then disc drusen. But disc drusen is not that common. So we'll just mention the three things. What three things you have to mention? You have to mention keratoconus. You have to mention
Sir.
three things you have to mention. Keratoconus you have to mention. You have to mention open angle glaucoma. You have to mention myopia and PSC in the lens. Okay. Yeah, so my question was to perform a dark adaptation ERG in RP to find out that the dark adaptation has reduced. My question was, where do you do EOG? EOG.
Where
Where do you perform EOG? Indication. What indication you perform EOG?
I don't know, sir.
It's very, very simple. EOG is only for best disease. Best disease, you only perform EOG. There is no other place where EOG is performed. Okay?
Okay, sir.
Anywhere else, when you're talking about a rod dystrophy, cone dystrophy, dark adaptation, light adaptation, it's always ERG. Okay? What is the other place where you see salt and pepper retinopathy? It is also a disease in young boys, 20-year-old boy, 50-year-old.
Birdshot, I think a birdshot retinopathy in that exam. In those pages, there was one salt and pepper appearance.
The most famous salt and pepper retinopathy disease is Kearns-Sayre syndrome, and it is associated with CPEO. What is the full form of CPEO?
chronic progressive external tongue.
It's a very severe disease, very intense disease.
This rubella salt and pepper appearance is there.
Yes. Rubella also has sort of appearance. CPEO is very intense. It's very, very sad. CPEO. I think that's it. I think this should be enough for RP. More than this, main points you need to know right off the tip of your tongue is don't bother too much about day blindness or color vision. Whereas day blindness is there. It's not that it's not there. Cone dystrophy is there. It's not that it's not there. But spend your time talking about the three cardinal signs of RP. Spend your time talking about the mode of inheritance of RP, which is getting more and more important by the day. We could have skipped it previously, but we cannot anymore. They might ask you what is X-linked recessive. They might ask you who do you think is most likely to be infected in an X-linked recessive, or they might ask you what chances or of which gendered offspring is it having a higher propensity towards an X-linked recessive disease. Some things like that. If you read it properly, you will be able to answer all the things. Treatment not much, but they might ask you newer modalities on treatment like gene therapy, stem cell, and there is what else? Implant, retinal implants. Okay. Okay. This for today. See you guys tomorrow then. Bye. Yes.
Sir, will they ask us about systemic diseases like you have this Alport syndrome, then Rush, and all those things are there, associated with retinitis pigmentosa?
Refsums.
Will they ask us Refsums disease? Will they ask us that also?
I don't think so, Alia. I don't think so because they are instructed specifically to not ask about anything apart from this. And on top of that, there are some diseases that are ocular associated which have a very strong systemic preponderance, like a thyroid eye disease. There, the extent of, for example, let's say myasthenia gravis. Ocular myasthenia and systemic myasthenia are associated together because you have to send the guy to the general medicine guy. But in these cases, I don't think they will. It won't hurt you to know them, but I don't think they will. Okay, guys?
Okay, sir.
Okay, take care. See you guys tomorrow.
Thank you, sir.
Thank you. Bye.
Got that triad from another book, right?
You want that?
No, like which book?
FAQ.
Okay. Yeah, sir, the in Wills, like, it's totally different.
This is actually the different sitting in front of you. He will not even waste the important things.
Triad.
He will only tell you the exact. He's like a good senior who will not ask you theory questions at that wrong time. He will give only the help, whatever you do.
In this class, we never mentioned that vitreous, it's not necessary. That's something.
Yeah, see? Vitreous.
Never.
I have never ever seen vitreous ever, and he's mentioning it the first thing. It's so straight. And Wilza is not a stupid guy. He's saying something means I either have to pay attention to it or I don't know. See, this is what happens when you are training at an elite level. When you're training at a level of a super specialty, you actually actively become the guy who's avid as an expert as the guy you're studying from. So you can always have a difference of opinion. And
Even we are Wills, we are even such a very high level, we
you're still able to disagree with them.
अस्सलामुअलैकुम वरहमतुल्लाहि वबरकातुहू सर। वो कल मॉर्निंग में आके लेके जाओ बोले लो एनओसी, अभी एनओसी के लिए डाल दिए। आप क्या बोलते हैं एनओसी के चार्जेस वगैरह पे करने का है, पे करें तो क्या बोलते हैं आप 720 है। कल 11 बजे आके ऑथराइजेशन लेटर डालो बोले, कस्टमर का ऑथराइजेशन लेटर, पैन कार्ड, आधार कार्ड, मेरा कस्टमर का पैन आधार कार्ड के ऊपर साइन और मेरा आधार कार्ड पे मेरी साइन ले लेके और बोले तो एनओसी हैंड ओवर कर देते बोले, 3 महीने की एनओसी बना के देने के बोले सर। और ये हुआ इतना तक अभी हुआ सर काम, और अभी तक इतना काम हुआ। और भी बिना तो मैं कॉल कर रही हूँ मतलब
This is a gold plated iPhone. I just asked what is the price.
Very good.
I just asked what is the price because this is the ultimate flex. If you have this, there's no more you need to flex. Now, should you flex or should you not flex? That is a separate question. But if you want to flex, the
It's like
easiest.
Dubai sheikhs, you know.
Yeah.
They are the